Great. Welcome. Today we're hosting Dr. Jean-Claude Katte. He's a postdoctoral research fellow at University of Exeter in the UK, and he's going to be speaking to us about the specificities of type 1 diabetes in sub-Saharan Africa. Just a little bit about him. He's a Cameroon-trained general practitioner, public health physician, and early career scientist specializing in global health diabetes research. After graduating from medical school at University of Yaoundé, Cameroon, he worked as a medical doctor and general practitioner in a semi-urban setting in Cameroon, where he pioneered the creation of a primary diabetes care clinic with strong community engagement. He completed his PhD from the University of Exeter and researching the phenotype, etiology, and survival of type 1 diabetes in sub-Saharan Africa. He's a postdoctoral translational research fellow at the NIHR Exeter Biomedical Research Center, and his current research examines the etiology and pathogenesis of young onset diabetes, including type 1 diabetes in sub-Saharan African populations. Thank you so much for joining us, Jean-Claude. I'm really excited to hear more about your work. It's a really, sort of understudied area, but very important area. And I know that there's a lot of recently more interest in it in the US. In fact, I spoke to a couple of physicians, scientists recently at UCLA who said that they were really starting to do some deep dives into this population to learn more. So we can't wait to hear what you have to share with us today. And so take it away.
Thank you so much, Monica, and thank you to the Sugar Science and the JDRF for inviting me to share, bits and pieces of my research that I've been doing for the past, I would say 4 to 5 years since I started my PhD. So yes, I'm going to be talking or sharing with you on the specificities of type 1 diabetes in sub-Saharan Africa. And this is going to be the presentation outline, really straight, direct, on some generalities on type 1 diabetes. We are not going to dwell too much on that, but then we're going to delve into my study, which was dubbed the YODA study for young onset diabetes in sub-Saharan Africa. So for type 1 diabetes, we know that it is a metabolic disease characterized by severe insulin deficiency as a result of the autoimmune destruction of the insulin-secreting beta cells of the pancreas. And this has been, described a long time ago. And there is almost a triad in the pathogenesis of type 1 diabetes, which has to do with background HLA susceptibility for type 1 diabetes, of course, with hyperglycemia and markers of autoimmunity, which are the islet autoimmune markers. And we know that these islet autoimmune markers, or the islet autoantibodies, they appear before the clinical onset of the disease. And the common ones that are of really strong clinical significance are, for example, the insulin autoantibodies, which seems to be the first to appear, but there are other autoantibodies such as the GAD, of course, for glutamate decarboxylase, the islet antigen 2, and the zinc transporter, or the ZNT8. And we know that these antibodies and the dysglycemia that ensures are now used to classify type 1 diabetes into different stages, ranging from stage 1, when these islet autoantibodies appear, to stage 2, when dysglycemia appears, and then to stage 3 as well. Not to dwell so much on that, what do we currently know about type 1 diabetes in sub-Saharan Africa? As you rightly said, Monica, it's really under-researched, underfunded, and very little is known compared to the vast body of knowledge about type 1 diabetes that exists in high-income countries. One thing for sure we know is that sub-Saharan Africa currently hosts the lowest incidence of the disease. However, from data from the IDF, that is the International Diabetes Federation Atlas, shows that the incidence of type 1 diabetes has slowly been increasing in sub-Saharan Africa. This has been attributed mainly to a greater awareness of the disease over the past 2 decades, but also with the slow penetration of insulin use within that sub-region. And also, as I said before, type 1 diabetes in sub-Saharan African populations today, as we know, is poorly characterized. And there are some previous studies, some of them really good studies that have been conducted in some parts of sub-Saharan Africa that seem to suggest from their results that the phenotype of type 1 diabetes in sub-Saharan Africa is different from the classical phenotype we know in high-income countries or what we see in our medical textbook. For example, some of the studies conducted both in West and East Africa have shown really low rates of islet autoantibodies. And in some 2 studies conducted in Ethiopia, although in very limited numbers, show that most of the participants had significant endogenous insulin secretion, which seems to be contrary with what one would expect in typical type 1 diabetes. However, much studies have not really been done looking at the genetic susceptibility of the disease. A few studies have shown, however, that HLA-DR3 seems to be contributing to susceptibility. But as I did show in this paper, which I published as part of my PhD, The Phenotype of Type 1 Diabetes, where I reviewed a large number of these studies published from sub-Saharan Africa, that most of them were conducted in small numbers. And so really the true phenotype of the disease cannot really be certain. Also, just to mention, type 1 diabetes has a very high mortality in sub-Saharan Africa, ranging from 20 to 40%. So all of these, we think, really can destabilize the current picture of type 1 diabetes we see. And so this is the reason why we actually started this study back in 2019 with the main aim to determine whether individuals with a clinician diagnosis of type 1 diabetes actually have autoimmunity, because as we know, as type 1 diabetes is defined, that it is, first of all, an autoimmune disease. And so we carried out this study in 4 different sub-Saharan African countries. So it was a multi-center cross-sectional study where we recruited people with a clinician diagnosis of type 1 diabetes. And diabetes had to be diagnosed before the age of 30 years. And they were all on insulin treatment at the time of recruitment. We assessed for autoimmunity using a triple assay of GAD, IA2, and ZNT8. And most importantly, we actually used population-derived thresholds for positivity, which was derived from non-diabetic populations from sub-Saharan Africa. We also assessed for beta cell function using a post-meal C-peptide test. And we calculated the type 1 diabetes genetic risk score using a 67 SNP genetic risk score, which was first developed and published by Richard Oram from the University of Exeter. And so in this analysis, I'm going to be showing you data from Cameroon, Uganda, and South Africa only, and Tanzania. Data from Tanzania has been excluded. So we started off with over 1,000 participants, and we ended up for this particular analysis with 800 participants from the 3 countries. As you can see, 248 from Cameroon, 370 from Uganda, and 182. After we had excluded individuals with a BMI greater than 30, given that these individuals have a high likelihood of type 2 diabetes. And so this table, which is rather busy, shows us the routine clinical features of these individuals who were diagnosed as having type 1 diabetes. As you can see, the median age at diabetes diagnosis is at 15 years for the overall population. It was slightly higher in the South African population, but all the other main features, such as the BMI 21.6, so showing that they are generally slim, HbA1c is high, showing them poorly controlled, and the plasma C-peptide levels are really low, with the overall population at 72 picomoles per liter. So looking at these clinical features, one would easily say these individuals look like they've got early onset type 1 diabetes because they are diagnosed young, they are slim, and plasma C-peptide for beta cell function is really low. So when we looked at the presence of islet O2 antibodies in these participants, we strikingly found that the majority of these individuals were negative for all the islet O2 antibodies tested. And as you can see, multiple islet O2 antibody was extremely low in this population. And even when we considered individuals who were close to diabetes diagnosis, especially those who were diagnosed less than a year, islet O2 antibody negativity was still extremely high in all three countries, as you can see in Cameroon, Uganda, and in South Africa, with an overall prevalence of islet O2 antibody negativity at less than 1 year of diabetes duration of 61.4. So this really, or this suggests that the duration of diabetes may not fully explain the absence of islet O2 antibodies within this particular population. So secondly, we looked at talking about islet O2 antibodies still. When we look at the individual islet O2 antibodies, as you can see, GAD seems to be the most prevalent islet O2 antibody within the population in all the three countries. And when we considered individuals who were islet O2 antibody positive, overall, they were diagnosed young and slim and showed severe insulin deficiency when we consider the C-peptide less than 200 picomoles. And so this picture is consistent with what you would see in classical type 1 diabetes, even in Western countries. And interestingly, also, these individuals who were islet O2 antibody positive showed a significantly high type 1 diabetes genetic risk score compared to individual population controls from the three different countries. So this really points to the fact that individuals who are islet O2 antibody positive in sub-Saharan Africa show features also of classical autoimmune type 1 diabetes as elsewhere. And GAD islet O2 antibody appears to be the most common islet O2 antibody in this population with very low rates of IA2 and ZNT8. When we looked at the individuals who were islet O2 antibody negative now, we decided to compare their features, those who were islet O2 antibody positive. And forgive the busy table, but you can see from main clinical features, for example, age at diabetes diagnosis, they were all diagnosed at 15 years, irrespective of islet O2 antibody status. And the BMI was not different in both groups as well. However, parental history of diabetes in whether father or mother was significantly higher in individuals who were islet O2 antibody negative. So one would conclude from these that to really separate these individuals who are islet O2 antibody negative and positive only using clinical features may be difficult. And so we decided to look at their beta cell function by looking at the plasma C-peptide. So when we look at the plasma C-peptide levels and we look at the rates of individuals who have insulin deficiency using C-peptide less than 200 picomoles per liter in green, we see that those who are islet O2 antibody positive, however, are more insulin deficient than those who are islet O2 antibody negative. But however, these rates of islet O2 of insulin deficiency are still extremely high, even in the group of individuals who are islet O2 antibody negative, as we can see that insulin deficiency is greater than 60% in both groups.
Jean-Claude, just quickly, we have a question in the chat
yes.
From Maria Redondo. Were insulin antibodies measured in those less than 2 weeks out in these studies?
Can you say less than 2 weeks out? Can you explain that, please?
I'm sorry, 2 weeks from diagnosis. So in the first 2 weeks.
Mhm.
Okay, so we have a really minute proportion of individuals who were diagnosed within that gap of 2 weeks. So as I said, when I showed individuals who were diagnosed less than a year, I think which is the closest one we've got in terms of their numbers. You can see from Cameroon 49, Uganda 54, South Africa 29. And however, we know from current literature now that, for example, GAD and IA2 are very stable markers with and so even in long duration diabetes, you would find individuals with true autoimmune diabetes still having GAD and IA2, but this is different from ZNTH, which seems to vary with also age of onset.
Thank you.
Oh, right. Yes, and so, yes, I'm just going to continue. So when we looked at genetic susceptibility for type 1 diabetes in those who are islet autoantibody negative, yeah, we see that the type 1 diabetes genetic risk score was substantially lower compared to those who are islet autoantibody or antibody positive. So this result coupled with the fact that they are islet autoantibody negative, also seems to suggest that these individuals from sub-Saharan Africa who do not have islet autoantibodies, who are diagnosed at a similar age as those who have true autoimmune type 1 diabetes, have insulin deficiency, although less severe, but have lower genetic susceptibility to type 1 diabetes compared to individuals who are antibody positive. And so this, when we saw these results, it was striking in the sense that not only were the islet autoantibody negative, but the genetic risk score, which we know is strongly captured by HLA markers, which are also responsible for the type of islet autoantibodies individuals present, were missing in this particular population. And so we decided to look elsewhere, that's away from sub-Saharan Africa, and with collaboration from the Search for Diabetes in Youth study, that's the Search study in the United States, we were able to obtain data to start some preliminary analysis and try to compare what we are finding in sub-Saharan Africans with African Americans, for example, in the US. And when we looked at the search data from this pilot analysis, we saw that those who are islet autoantibody positive in sub-Saharan Africa, the rates were substantially lower than, of course, Black Americans in the search cohort, but also white Caucasian participants in the search cohort. As you can see, if you are from a white ancestry, the rate of islet autoantibody positivity is at 90%, which is what we usually see in medical textbooks, that are written. But if you are from sub-Saharan Africa and you are diagnosed with diabetes less than 20 years and within 1 year of diabetes duration, because we match the population to fit the search recruitment criteria, we see that islet autoantibody positivity is just at 40%. And so we decided to look at the type 1 diabetes genetic risk score in these individuals as well. And those who were islet autoantibody negative from sub-Saharan Africa, as I said previously, within this group, match with the same search recruitment criteria. The type 1 diabetes genetic risk score is significantly lower compared to those who are islet autoantibody positive. And this pattern was mirrored in Blacks as well in the search cohort, who also presented with a substantially low 1 diabetes genetic risk score compared to those who are islet autoantibody positive. But individuals who are from white ancestry, when the type 1 diabetes genetic risk score was similar, irrespective of the islet autoantibody status. So what does this mean? It means that if you're white Caucasian, for example, and you're diagnosed with type 1 diabetes, with a clinician diagnosis of type 1 diabetes, and you are islet autoantibody negative, it means that the genetic susceptibility, it's really not different. And so you would probably have what people might term islet autoantibody negative type 1 diabetes. But if you are of Black ancestry, then it means that it may be different. It may not be islet autoantibody negative type 1 diabetes. This type of diabetes may completely have a separate etiology. And so what we found within sub-Saharan Africa in terms of summary is that in individuals who have a clinical diagnosis of type 1 diabetes, there is some heterogeneity in the pathogenesis, and that while a minority of individuals present with classical autoimmune type 1 diabetes within this population, characterized by islet autoantibody positivity, severe insulin deficiency, and a high type 1 diabetes genetic risk score, most of the participants actually do have an atypical form of the disease, which is characterized by islet autoantibody negativity. Of course, less severe insulin deficiency compared to those who are islet autoantibody positive, but really a lack of the type 1 diabetes genetic susceptibility that one would see in classical type 1 diabetes. And so we think that this data actually supports the existence of a non-autoimmune form of the disease or a form of diabetes, which is characterized by severe beta cell deficiency, but without islet autoimmunity, which we've called non-autoimmune severe beta cell deficient subtype of diabetes. And that preliminary data from our analysis also shows that this particular subtype of diabetes or manifestation of diabetes also do occur in Black individuals within the search cohort, but albeit at a lesser degree than true classical autoimmune diabetes in that population. Now, this is where we are with the research, and we hope next steps in terms of perspective to try and dive deep to understand what are the drivers of this, or to understand detailedly the phenotype of this particular diabetes manifestation and what may be other possible drivers of this condition within sub-Saharan Africa. And with that, I'll end by thanking or acknowledging my supervisors, both in the UK and from Cameroon and Uganda, and other colleagues. And of course, the funders of this study, which were the NIHR. And also, thank you for inviting me, and be glad to take some questions.
Thank you so much. This is a fascinating new discovery, or, kind of, data set that you've unearthed here. We do have a couple of questions. Rodanthe Zadrilli, I can't really see that. Jean-Claude, thank you very much for your interesting study so far. Is there a case that assessment of the autoantibody levels was done at a later stage of T1D? Maybe the mass of beta cells was already lost. What are your thoughts on that?
Yes, that's true. Maybe the mass of beta cells was already lost. As we can see, that is reflected in the fact that both groups actually had very low C-peptide levels, showing that they've already undergone probably significant beta cell loss. But however, we think that when we look at the fact that we've assessed islet autoantibodies, but not only islet autoantibodies, but background susceptibility using genetic risk scores, of course, which have been shown to discriminate type 1 diabetes from other forms of diabetes in European population, of course, because these were developed in European populations, but they've also been shown to work really well in African Americans in the US with Hispanics and Indians. I think there are a couple of studies that have been published within the search cohort and with colleagues from India. And so we think that this at least can give us an idea into background susceptibility for type 1 diabetes within our population. Although we understand that some of the alleles that are captured within DR3 or DR4, because these contribute 50% to the score, may be different in African populations. And so, yes, I've also tried using other mathematical techniques to kind of evaluate the proportion of individuals who we think may have antibody negative diabetes within that group. And for now, what we are seeing is that that proportion is just about 10 to 20%. So that really shows that a huge proportion of that antibody negative group still have this really atypical background susceptibility.
Thank you very much for answering that question. Here's another question from Maria Redondo. Did you try the African ancestry GRS, Onengo, Gumosku? Were you able to, and then the second question is, were you able to test for MODY?
Really good questions. So we have also sort of calculated the I think the 7 SNP score. I guess that's the 7 SNP score that was published by Onengut Kumusku, and we've shown actually within the data set that it performs almost similarly to the 67 SNP. And we also tested the 30 SNP, which was previously published by Richard Oram, and the performance of the 30 SNP was really low within our data set, just as it was low within the African Americans, even in the search cohort. So if it's impossible to use the 67 SNP, I guess Suzanne's 7 SNP score will still work perfectly in this population. And in terms of perspectives, at the moment, I've carried out some pilot monogenic diabetes analysis only within the Cameroonian cohort. And I tested individuals who are islet autoantibody negative and C-peptide positive. So those who had significant C-peptide secretion. And out of 60 individuals who were tested, who met that criteria, we picked up 5 individuals with monogenic genes of diabetes. So representing approximately 2%. So which is not very different from what has been published in the United study in the UK, or 1.2% published in the BDD study in Sweden, not very different from pediatric studies in the US as well. So really pointing to the fact that monogenic diabetes may not be contributing to this atypical type of diabetes in the African population.
Is it 2% out of your autoantibody negative?
That's 2% from the total population,
Sure.
From the total cohort, Cameroonian cohort tested. We plan to do more testing, but yeah, that may take some time due to funding and other things.
Yeah, thank you. But I guess the question is whether that is a large, quite significant percentage of your autoantibody negative population, and your antibody negatives is a higher proportion of your total diabetes. So, but yeah.
Yes,
thank
that's
you.
true.
We have another question here from Martha Stewart. Thanks so much for this great talk. What are the practical implications for clinicians on the ground? She asked.
That is a very good question, I guess. I think we showed that in terms of clinical features, it's difficult to distinguish who is going to be islet autoantibody positive or negative. The truth of the matter is that in most clinical settings in sub-Saharan Africa, these are not tested. And so when individuals are diagnosed young with diabetes, the natural tendency is that they go to the type 1 diabetes clinic. And the fact that they are also insulin deficient should lead clinicians to treat these individuals with insulin irrespective of the level that we might want to put them. So from a clinical standpoint, they should be treated with insulin. They are insulin deficient. But from a research perspective, it will be important to find out if this is not type 1 diabetes, as we are showing, at least for the majority of these individuals, are there other causes, for example, from the environment that are leading to beta cell assault leading to beta cell deficiency. And if we try and identify these drivers, then it might lead to, prevention. We don't know what this may be at the moment, although we have a couple of hypotheses that we would want to test.
It's fascinating. This is really such an interesting, part of the T1D story. And it's so great that you're really sort of digging into these data and getting more and more information around this. I don't know if you want to call it an endotype, but a new way, a new understanding of presentation. I also wanted to ask you, what are your thoughts about, or has any work been done regarding those who are coming from sub-Saharan countries, emigrating into these sort of northern countries? I know there's been some research that's shown, that some people, some populations emigrating into these sort of Nordic high type 1 incidence population or countries like, Finland or something, they then become themselves more susceptible to getting type 1. Is anyone looking at those populations and whether or not they are kind of fitting this, this presentation style of the sub-Saharan population, or actually more of the sort of, country of origin or the country that they're emigrating to?
Yes, so I think that is true in this, first of all, in the sense that for the few studies that have looked at immigrants from sub-Saharan Africa coming to Europe, for example, we know that the incidence of type 2 diabetes will increase and match their European counterparts. And even for type 1 diabetes, for some Sudanese populations that have been studied in Europe. I think since I presented this work at, for example, the Diabetes UK, I've had several colleagues who see African patients in their clinics concur that they've got patients that they've tested and they seem really to be atypical. Now, I think we really just need to do more research on this population. And we know that comparing our data with the US or African Americans, may not be ideal, since, in terms of admixture, the African American population seems to be very, very different from, native sub-Saharan Africans, obviously, because of migration and all the change. So I think some of the keys to this would, will be detailed study of native Africans within sub-Saharan Africa, to try and understand the interaction between the environment and also background genetic susceptibility in leading to type 1 diabetes or other forms of diabetes subtypes, which we may not know.
Yeah, no, there's so much room to really work and understand. Oops, here's one last person coming in. What is going on here. And I think, these data can serve to illustrate actually, the sort of the 360 view of what happens during type 1 diabetes. In many different, there are many different roads to type 1 diabetes, and this is another one and an important one. You have a lot of accolades in the chat. Thank you very much. These findings regarding the presentation of autoimmune type 1 diabetes are revolutionary, excellent data. So thank you again for joining us. And this is really exciting work, and we can't wait to see sort of where you're going to go with this next. We'll be watching for papers coming from your laboratory.
Thank you so much, Monica. I would say two things before I end, if I may.
Yes.
The first one is regards to comments about the NPOD. Of course, there are some donors, I think, within the NPOD of African ancestry that I know Sarah Richardson here in Exeter has been also looking at, but native Africans are still lacking. We think that obtaining, pancreases at some point might also give us some key, pointers to the etiology of these disease. And we've started these discussions with colleagues on the ground, just looking at, the ethical and social implications of pancreatic donations for studies, because as you may know, these things can be really tricky within a typical African setting. And so that discussion is currently going on, and we hope it's going to bear some fruit. And lastly, I would end by saying that really our understanding of type 1 diabetes as a whole will never be complete if we don't understand type 1 diabetes within the African population.
Agreed. Thank you so much for leading the charge here and bringing this important cohort to, to bear. Again, we wish you the best, and we're looking forward to, what happens next as this whole piece of important information evolves. Thanks again. Oh, a lot of accolades one more time. Thank you again, and have a great rest of your day.
Thank you very much. Bye-bye.
Bye-bye.